A patient sits down in your chair and says, "Part of my vision has just disappeared." Welcome, focus learners, to a high-stakes explainer where we are going to approach visual field loss not just as a simple symptom, but as a full-blown clinical detective challenge.
Think about it. That one single symptom, that's our crime scene, and it is incredibly broad. It could literally mean anything from a sight-threatening retinal detachment to chronic glaucoma, all the way to a life-threatening brain tumor. So the ultimate question we need to answer today is, would you know which one needs an emergency referral and which one just requires routine monitoring?
Okay, here's our roadmap to solve this. We'll start with visual field map clues, master the clinical history, weigh unilateral versus bilateral culprits, examine the physical evidence, break down referral urgency, and then test your skills with some rapid-fire clinical case challenges.
Let's dive right into Section 1, Visual Field Map Clues. Every good investigation needs a map, right? Well, in optometry, the visual field is exactly that. Now, the absolute crucial point to remember here is that visual field loss is just a symptom. It's not the diagnosis itself. A field defect basically just tells you, hey, damage occurred somewhere along the visual pathway. Our job is to find out where. Our primary suspects usually fall into three camps: a retinal problem, an optic nerve issue, or brain disease. And the location of that defect? It leaves distinct clues pointing straight to the culprit.
All right, moving on to Section 2, master the clinical history. This is the interrogation phase. You have to ask the right questions to get the right clues. Was the onset sudden? Boom, that immediately raises your referral urgency. Is it a purely central loss of vision? You should suspect the macula right away. What about a peripheral curtain coming down? We're instantly thinking retinal detachment. And flashes are huge too. Flashes in one eye usually mean a retinal tear, but flashes in both eyes point us toward a brain cause, like a migraine aura. You also absolutely must ask about the duration of transient episodes, because these often don't have visible signs when you look in the eye. Your history is literally everything here. This is the battle of the transient episodes. If that visual loss lasts just a few seconds, you really need to be thinking TIA, a transient ischemic attack. But if that episode stretches up to an hour, you're much more likely looking at a migraine. That timeline is your smoking gun.
Section 3, Unilateral versus bilateral culprits. Simply asking, does this affect one eye or both, is probably the most powerful binary decision tree in your entire detective toolkit. It cuts your suspect list right in half. If the defect is unilateral, just one eye, your primary suspect is the retina or the optic nerve. But if the patient tells you the loss is bilateral, affecting both sides, the brain is almost certainly the culprit. It's such a simple rule, but man, it is incredibly effective.
And when you do start suspecting brain disease, you have to actively hunt for systemic red flags. Never, ever miss neurological symptoms. Ask them directly, do you ever have vertigo, limb weakness, or numbness? Because these are glaring red flags. If you see these combined with visual field loss or bilateral flashes, that demands you investigate for brain disease, and you should strongly consider a dilated exam to check for papilledema.
Okay, on to Section 4. It is time to examine the physical evidence.
Now, as a responsible clinical detective, safety absolutely comes first. Before you even think about dilating your patient to find the culprit in the back of the eye, you've got to do a pre-dilation check. Check the anterior chamber depth using techniques like the Van Herrick method. Ensuring that angle is safely open means you won't accidentally induce acute angle closure glaucoma while you're busy trying to solve the first mystery.
All right, once we are safely dilated, we look internally. What we're looking for here is Schaeffer's sign, those tiny suspended pigment particles floating around in the anterior vitreous. We often call it tobacco dust. If you see this, it is a massive, screaming clue indicating a retinal tear or a full-on retinal detachment. It's physical evidence you simply cannot ignore.
And then we compare the optic discs. Pathological cupping with a thinned neuroretinal rim? That indicates chronic glaucoma. But what if you see an elevated, hyperemic, swollen disc with blurred margins? That points directly to acute optic neuropathy or brain disease. These are two very different pieces of physical evidence, leading you to two very different diagnoses.
Section 5, Referral urgency and decisions, because finding the clues is pointless if we don't act appropriately.
When you are dealing with a retinal detachment, you are in a true race against time. If a patient comes in with a curtain of vision loss, low intraocular pressure, and Schaeffer's sign, but you look and their macula is still perfectly normal, that is a macula-on retinal detachment. This is a massive sight-threatening emergency. The central vision can actually still be saved if you act immediately. On the flip side, if the macula is already elevated and pale, it's macula off. They both absolutely need referral, but that macula on scenario, that is an absolute same-day emergency.
Now, for optic neuropathies, your urgency is really driven by the onset. Acute optic neuropathy is going to present with sudden vision loss, unusual headaches, and a swollen disc. Progressive neuropathy is gradual, maybe with a pale, atrophic disc. But whether it's sudden or gradual, you have to remember the golden rule of this explainer. Repeatable visual field loss always requires a referral. Verify the defect by repeating the test and then refer.
All right, section 6. Let's put these new detective skills of yours to the ultimate test with some rapid-fire clinical case challenges.
Case number 1. Take a second to process these clues. Your patient reports a curtain descending over their vision and new floaters. You check them out and find low IOP, plus tobacco dust in the vitreous. But crucially, the macula looks totally normal. What is your diagnosis, and how fast are you acting? Think about it. You absolutely nailed it if you said macula on retinal detachment. Since the macula is still attached, their central vision is preserved for the moment. This mandates a same-day emergency referral to a specialist. Get them out the door.
Okay, keys 2. A patient comes in complaining of transient visual loss. During your history taking, they casually mention these episodes last only a few seconds at a time. You check their medical history, high blood pressure and heart problems. The timeline is the smoking gun here. What condition lasts only seconds? That is a classic TIA. Because transient causes like a TIA often leave absolutely zero visible signs on the slit lamp, your detailed history taking is what actually solves the case. The cardiovascular risk factors, plus vision loss lasting mere seconds, point straight to this life-threatening vascular event.
Final case. A patient complains of vision loss and weird, unusual headaches. But wait, during the history, they also admit to having some vertigo and limb weakness. You run the visual fields and boom! You discover the field loss is bilateral. Look closely at that combination of bilateral issues and those massive systemic red flags.
The verdict here is brain disease. Bilateral visual field loss paired with neurological red flags means they need an urgent medical evaluation. So keep this entire framework in mind, trust your history taking, trust your detective instincts, and never ignore what the visual field map is trying to tell you. When the next patient sits in your chair complaining of a blind spot, will you just see a symptom or will you see the map to solving their clinical mystery?